Thank you, Rachel, and thank you to the organizer for inviting me to this meeting. I am learning a lot, and I'm going to talk today about some of the challenges that we have been facing in Mexico in our efforts to try to prevent and control obesity. Last year, Juan Rivera, who is the director of the National Institute of Public Health, was here, and he talked about the epidemic of obesity in Mexico, which is one that has been documented as is one of the ones with higher prevalence in the world. This is just to show you. We have 72.6% of the population with obesity and overweight. Is one of the highest prevalence of obesity in the region, and it has been increasing since 1999 that we have been evaluating with national surveys. The result, as you saw from the first sessions today, is that we have a very high prevalence of diabetes, a high mortality, 9.34%. So we are one of the countries with highest mortality due to diabetes. So the government in 2016 declared a national epidemic alert, which is something they tend to declare for chronic disease, for infectious disease, but not for chronic disease. And we are the first country to declare an epidemiologic alert due to diabetes. And there are some successful initiatives to prevent obesity that have been going on in Latin America, such as the soda tax that was implemented in Mexico in 2014, and since then in other countries like Chile, Ecuador, and Peru. And there are many other Latin American countries that are running initiatives to follow this model. The front of pack warning labels in Chile that have been now implemented in Uruguay and are going to be implemented in Brazil and Peru. The school healthy eating guidelines, which are very interesting, particularly the ones in Brazil, which, as Fabio was telling, are more related to basic foods locally produced than to ingredients and profiles. Marketing restrictions in Chile, Brazil, Uruguay, and active transportation and physical activity, which has been implemented in many countries of Latin America, but mostly Colombia has a very good experience with a lot of publications about the effectiveness. So this is how the soda tax looked in Mexico after 2 years of evaluation. We were able to demonstrate a reduction on average for the 2 years of 7.6% in the consumption. This sounds like a little effect, but in a country of 126 million inhabitants, this represents about 67,000 tons of sugar that were not consumed in this 2 years. So it's very important. It's an excise tax, so it reduces the amount with the inflation, but it is adjusted after every year. It's adjusted again. So right now we know of many other countries that have better designs of taxation that we can use to refine our model. But this was one of the big policies that Mexico had and that have been taken as a model for other countries. We know from Chile the importance now of front of pack labeling and regulation of marketing. So you can see here the Mexican product and the equivalent in Chile. So we have use of cartoon characters, is endorsed by sports leagues. It has the very misleading front of pack labeling system that was created by the food industry, and is based on 92 grams of sugar a day, which is highest than any recommendation. In Chile, they have these big two octagons that say high in sugar, high in calories, and they don't have this character. So it's very important as a success. And some of the challenges that we have in the region and in Mexico are the double burden of malnutrition. That is still, although as a country we have very important reductions of stunting, for example, as one indicator of or anemia. It is still very important in low-income areas and rural areas. Also, most of our inequalities are related to socioeconomic status. So it's not a race, but a socioeconomic status. You can have people from any background or mostly from any mixture of backgrounds in different socioeconomic status, but for poverty is very associated, and it has a very high risk of having obesity, and I am going to show you some of these challenges. Also, interference of industry in the policies, and this is something that is becoming a big problem to advance with some policies that we already know that are cost effective. Scarce resources to invest in obesity prevention, that's also a reality. We are not in compliance with the recommendations of investment or proportion of the gross national product investments in health. And from there, investment in prevention is very low. And primary health care and the first level of attention have a huge challenge because our systems were created in a period in which the main diseases were infectious diseases, so we don't have a proper system or training or attention for chronic diseases. And this is just to show you at the beginning of this administration that is going to finish in 1 year. So this was 6 years ago. They were very motivated to combat hunger in Mexico in low-income areas. And one of the first things they did is they announced this big crusade against hunger, and it was signed by Nestle, PepsiCo, and Coca-Cola, and they were going to poor communities to combat undernutrition. So this is the kind of things that are very important and that reflect the importance of understanding the causes of malnutrition in all its forms. This obviously this was then removed when civil society organizations and academia were talking and giving opinions about these initiatives, but this was like 1 or 2 years the main activity in poor income areas of the government, particularly in a country in which low income areas have very poor access to water and to clean water and potable water. And this is also something that is very common in Mexico, in the south areas like Oaxaca and Chiapas. In every town, indigenous towns, some of them without speaking language, the Spanish language, they have welcome signs with promotion of this soft drink, and this is very common and is also very used since children to adults, and is one of the things that we are watching not that much in high-income areas. So we have been evaluating points of purchase in 5 countries, and this is an example of a high-income supermarket in Mexico. So you don't see that much advertisement directed to children. However, in low-income supermarkets, you see this kind of pictures where they need to be really aggressive in promoting their products. So you have here the healthy food sections, and you have the promotion of soft drinks there. And the reason is healthy foods in Mexico are very inexpensive. You can buy for $1 4 kilograms of watermelon, or 2 kilograms of platano, 1 kilogram of mango, 2 kilograms of tomato, 1 kilogram. So it's very inexpensive, healthy food. So they need to be twice as aggressive as in developed nations to sell these kind of products. And we have been evaluating that, and you see, for example, that in low-income supermarkets, there is a highest proportion of advertisement in points of purchase directed to children. So this is soft drinks. Is 44.9% for low-income stores compared to 19.5% in high-income stores. And this is the same for these 5 countries that are Chile, Brazil, Argentina, Mexico, and Costa Rica. And these are some of the things that we have been watching, like targeting children with product placements, cartoon characters on packages, price discounts, images, gifts, incentives. And this is very, very common. And it works because when we ask what are the things that they bought without prior planning, the more frequent are sugar sweetened beverage, sweet snacks, salty snacks, and breakfast cereals. So we have also some opportunities in the region, in Latin America and in Mexico. The problem of obesity has now very high political visibility. The Latin American region is very well communicated, integrated, and some of the policies have domino effects. So now the academia is working almost as the same group. We learn very quickly what is going on in Chile. We know what is happening in Colombia. They ask for our advice and we ask for their advice. So this is having good results, and that's an opportunity. Also another opportunity is that we know that the cost-effective interventions that we need to implement to prevent obesity, many of them do not need expensive technology. It's not like we need genes evaluations or very expensive treatments. And so solutions can be replicated also in low and middle income countries from other areas of the world. So this can have very important benefits. So let me show you some of the difficulties we are experiencing in Mexico. For example, we adopted this GDA labeling, which is the one that many countries have in developed countries. It was made by the food industry. It's very complex. It has many numbers. It's misleading because it has a quantity of sugar that is way above the recommendations. And this is the one that Chile developed, which was developed by academics. And this is the difference in these two labelings. This was approved in Mexico as a law in 2014. And the problem is that with this information, this circle combined with 4 other similar circles is very difficult for a common person to take a decision about this food. In Chile, even the kids know that when they have these octagons, it means that there is something wrong with the product. It's high in something. So in Mexico, we have been developing some evidence that the GDAs are not working. We published a study in 2010 in which we evaluated students' understanding of the GDAs, and they did not understand. Nutrition students, in college nutrition students. Also in 2016, in the national survey, the respondents responded. The respondents say that they prefer a warning label over the GDA, and this was in the UNICEF study, and in the national survey, only 13.8% responded that they understand the GDA. So it's a system that is not well understood. In high-income population, in this multinational study, we found that 54% responded that they understand the GDAs, but 83% responded that they understand the Chilean system, even though they have never seen it before, and this has been promoted by the national government. Also, the GDAs are harder to understand by low-income and other vulnerable groups, and that was another result of this study. And the reason why we have this GDA labeling system and not a warning label system has to do with this Mexican Observatory for Obesity, which is what the government created to take all the decisions regarding obesity prevention in Mexico in 2012. And as you can see from the chairs, half of them are representatives of food industry associations, chambers, industry-related organizations, civil society, industry-related organizations. So basically, all of the attempts to do some prevention in labeling, marketing, schools were stopped at this with this mechanism. Now they are recommending in other countries to develop an observatory of obesity with the lobbyist groups, saying that this system worked very well in Mexico, and we are trying to convince them, and we have published some evaluations of how the process goes when you have this kind of interference from industry. This is one of the associations that is in this observatory, and as you can see, it is Mexico, and it represents mostly multinational food companies. Most of them produces sugar-sweetened beverages, and many of them also produce junk food. And they were basically against all the public health initiatives that were submitted to the observatory in this period. So in the National Institute of Public Health, what we did to change or to show evidence of other alternatives to front-of-pack labeling is to integrate a conflict of interest-free group of academics, and these were our recommendations. First, to use the nutrient level profile of WHO or PAHO, or the national one, and not just any arbitrary nutrient profile as it is currently in the labeling. Also, to use a conflict of interest-free group with a transparency criteria in deciding the front of pack. Also, to have a coordinated nutrient profile for all the policies. We have now a nutrient profile for marketing on TV, another for schools, and another for labeling. Then that it must be with simple labels like the one in Chile, and it should not include good nutrients that are added to the products just to make them look good. And also, one big conclusion of this group is that the GDAs do not work as an effective system to promote healthier choices. So this was published, and it is one of the things that we're giving to the new government that will start on January. So they seriously take again this problem of the front of pack in Mexico. And in this last part, I want to talk a little bit about the health system and the attention. So these are the figures of the total health budget in Mexico. As I said, we are very far from investing on health what developed nations are investing, and the percentage invested in preventing chronic disease from this budget is very low, 0.2 to 0.3%. So we have very low resources and a system that is not created to give care to chronic diseases. So we have a budget that is focused on other diseases. The health units lack the minimal equipment to evaluate and to make proper diagnosis of obesity. The physicians do not have adequate training. They were mostly formed in curriculum to combat pre-transition problems such as infections. The specialists are insufficient. In the whole country, we have less than 600 endocrinologists, for example. And it's not that we need them to treat obesity, but it's important in the reference system. And the users have poor adherence to treatment and motivation to change. Also, some of the primary healthcare challenges are that the obesity prevention and control are a critical component to combat the epidemiological alert, and we don't have that well placed in the health attention. We do not have evaluations of the interventions necessary to achieve efficacy and adherence, and very low budget. So whenever there is an intervention, there is not enough funding to evaluate it. So this is one of the challenges. And there is a major adjustments for NCD's financing and organization of health services necessary to control its growth through effective treatment of obesity. So these are the main challenges in the health system. And as a conclusion, I will say that we need double duty policies that are focused on healthy nutrition and lifestyles across the cycle of life. Mexico is one of the countries with the worst practices of breastfeeding. So we have both a lot of interference from industry, a very aggressive marketing in poor communities, and some of the lifestyles that we are adopting are affecting both undernutrition and obesity. We have we need to have a special focus on vulnerable population, particularly low-income socioeconomic status groups like rural south of Mexico. Regulations and taxation to improve obesogenic environment need to be refined. So we have this soda tax, but we can improve it. We can make it higher, and we can make it to be automatically adjusted for inflation. And some of these funds needs to be allocated to health attention. And finally, industry interference, particularly from multinational companies, needs to be addressed in the decision-making parts of the system. And also we need to to speak out about this internationally, because many of these companies say they want to be part of the solution in international meetings with international organizations, but at the local level they are really part of the problem, and they are not willing to accept any type of regulation or attempt of the government to improve the environment. Thank you.